What's good, YouTube? Welcome back to the Mega Rich channel. So y'all, I'm so sorry. I apologize for being so late with putting out new content. It's just been so busy adjusting to my new work life. So I'm working on the Med Surg Unit and I work nights. So that was just an adjustment within itself. So I sometimes work a day, off 2 days, or I'll work 3 days straight. Then I'm off like 4 days. So just a little bit about the type of patients I've been having on the Med Surg Unit. It varies from like patients with acute kidney failure, acute on chronic pancreatitis, IV drug abuse users, patients that are suspected of having cancer, sickle cell patients, patients with hydrocephalus, and so much more. So y'all, let me just tell y'all how my first shift went, and I'm just getting comfortable. I'm just outside at my grandparents like I told y'all, but my first shift, I was so stressed because I was learning how to chart and I had a preceptor and she was pretty cool. So how it starts off, you clock in, of course. You go to the board and see who's your patients, what they have, what's their room number, and who's the day nurse that you're getting report from on that patient who had them for that shift prior to yours. Then after that, you go to huddle, and huddle is normally from like 6:45 to 7. Sometimes could run a little longer than that. Just depends on what all happened throughout the shift. And then after that, you walk with your day reporting nurse to go get your patients, and they pretty much tell you what was going on with the patient during the day, what's like really important that you need to know. They tell you, a little bit of background of the patient, and also you do the 4 eyes on skin. So the 4 eyes on skin is very important because that pretty much allows you to see what's going on with the patient, making sure they didn't develop any pressure ulcers prior to your shift, because if it happens during your shift, then of course you're going to be held accountable because that can lead to a wound. So, you check the 4 eyes on skin, get a report, see if the patient is on any PRN pain meds, things like that, what's their pain. And before you leave the room, you always want to ask the patient the 3 P's: pain, potty, and position. Would they like to use the restroom? Do they need their position changed? Are they in pain? Do they need any pain meds? Because if you do that, after you get your vitals on these patients and also doing your assessment, when you go to get their meds, if you know they were in pain, you can just pull that particular pain medication, and it just limits, time on backtracking, trying to go to the Pyxis and just relieving them of the pain, because you want to do as much as you can for the patient, and you want to also cluster care and facilitate a quiet environment and just let them be able to relax, because of course when you're in the hospital, you're going to be anxious, you're going to be just worried about what's going on, and you're not going to be comfortable, of course, because you're not at home. It's not a comfortable setting. So that's pretty much how the beginning of every shift goes. Yeah, so I reposition myself because I don't know if it looks weird that I'm laying down, but also in the beginning of the shift, after you do all that, pain, potty, position, assessments, you want to go to your chart, go to your work list, and see which medications are important per patient that they need to get first. That way you can see what patients that you need to distribute medication promptly, whether it's a patient that's getting insulin, or if they're getting tramadol, or they're getting Dilaudid, or any type of pain medication, because you do want to give pain medication first all the time. You want to get that done. And you also want to get your blood pressure medications given out to your patient as quickly as possible after getting their vitals, and if they're in range to be able to get the blood pressure medication, because if not, you'll have to reassess their blood pressure if you wait too long after getting their vitals. So within an hour is pretty good. You can actually go ahead and still give that blood pressure medication if it's within an hour. So that's how I start my shift off. I go to my work list, see which meds I have to give, what needs to be done for each patient, and I go from there. So if I have time, I'll actually start charting my assessment for my patients, you know, what state they were in, where they're calm, accepting, cooperative, because that's very important to know if the patient is going through any psychological changes as well. Because like I said before, it can be stressful being in the hospital and scary, especially for people that maybe never had the experience of being in the hospital before. So you want to do that. And then you want to go to the Pyxis within time. So normally on my shift, my patients get medications at 9 p.m. So the earliest you can give it is at 8. So you have an hour before and an hour after time frame to give the patient medication. So going to the Pyxis was a little crazy for me because my first night I wasn't registered. I had to register myself in the computer, scan my fingers and stuff like that. So when the Pyxis pop open, when you click the patient name to draw whatever medications they're getting at that hour, the little drawers pop open, and I was like, oh my goodness. I was like, and it'll tell you like, for example, drawer 3, pocket 14 or 43. So the rows run vertically. So it took me a little while to see how the numbers were running, but it was like up and down from left to right. So I had to get used of that. So you get the medication out, you close the drawer, and you always make sure you sign out of the Pyxis, because you never know. You know, I'm not saying you can't trust people you work with, but you have to protect yourself at all times. So you make sure you sign out, because you don't want nobody going behind you and drawing out a narcotic under your name that you did not pull. So you always have to be safe. So after I do that, I get my meds. And for me, some people pull all their medications at one time for all their patients that getting it at 9. But I don't do that at all, because that's how errors can happen. Our wild courts don't have drawers to put the patient medications in. So you're basically keeping the meds on top of your courts. So there's no way to identify who meds is who, you know, unless you put it like in some big styrofoam cups and separate it and write their last names. But who wants to go through trying to do all that, meanwhile checking on your patient and just getting to them adequately? So I go to each patient room and I give their meds. And I always do my pain potty in position as well, because where I work at, we do hourly rounding. So it's very important to see if the patient needs anything, especially if you're short on PCTs, which are CNAs, but we call them PCTs where I work at. You want to make sure that you're being adequate in getting those things done, because if you don't have a PCT that night, or if you're short-handed, then you're delaying patient care, or you're not, you know, doing service for them. You always want to provide good customer service for the patient. So I do that. And after I pass all my meds to my patients, I go and I chart. I go do my assessments. I go see what else needs to be done during the shift, whether it's, you know, wound care. I'm sorry, I just had a brain freeze, because, you know, that happens sometimes when there's so much information to give. So we do wound care. You always monitoring the IV sites. You know, a patient might need a bed bath if the PCT isn't there. So you want to make sure you can get that done, and just other things that might just pop up randomly. So while I am just rambling on and on and on, I'm going to tell you guys how I feel about having 2 preceptors. So having 2 preceptors is like a great advantage as well as a little tad disadvantage, because you'll have one preceptor that likes to do things their way, and then the other, of course, likes to do things their other way. And when it comes to charting, one might be like, oh, you don't need this, that's over charting, and then the other one will go back and be like, no, you definitely need this. So it does get confusing when you have 2 different preceptors. Sometimes I wish that they would kind of communicate amongst one themselves and come on one accord. That way, it doesn't get too overwhelming for the new trainee, aka orientee, which is me, to adjust on how I'm actually supposed to chart, because if one person is telling me this and the other person is telling me that, and then one night I'm charting like this because I'm with this preceptor, then the next night I'm charting another way because I'm with another preceptor, you know, they're going to just be like, no, you need to do it this way. So it gets confusing, but you know, you always reach out, follow your chain of command. If you're having any issues, you know, you can always talk to your supervisor and be like, hey, this is going on. You know, what can be done about this, because I'm a little tad bit confused. Also, my second night, I nearly wanted to quit because my preceptor, he was just joking, but I took it seriously because, you know, it was my second night and I didn't know anybody, and I'm a new nurse, of course, and I just want to protect my license at all costs. I didn't know how to make sure, I wanted to verify with them on how to use the IV pump because, like I've said in a previous video, I had never been exposed to using their IV pumps at this hospital. We used old ones, so this one was completely new. I wanted to make sure I had it set correctly because they use channels on their IV pumps. It's like 4 different channels that you can hook up. So I wanted to make sure that I was hooked up correctly. The rate and the volume was to be infused was correct. So I did not want to throw my patient into fluid overload at all. So I went and asked my preceptor of the night, which was the female, and I was like, hey, do you mind coming and verify this for me? You know, I'm still kind of getting used to it. I just want to make sure I said it right. So he jumps in and was like, oh no, when you start training with me, you need to know this, because if it was up to me, I'll send you home because you need to know this. And I was like, oh my God, it's only my second shift, you know? So I kind of just got disappointed and just felt like this career is not for me. So I went home and just reevaluated things, and you know, we talked about it and he did apologize, so everything was cool. But it did kind of put a lot of pressure on me because I was like, I didn't learn a lot of this stuff, but it was only due to COVID, because clinicals for me ended early. And like I said before, I didn't do clinicals at this particular hospital. I was elsewhere. So, you know, I just felt scared, and I don't want to do anything to lose my license. I'm trying to just be safe and always be safe for my patients, because, you know, at the end of the day, I'm their caregiver at the time, and I just want to do the right thing. So that particular thing happened. And at my hospital, LPNs actually get new admits on the floor from the ER. So I actually had my experience so far for the past 3 weeks. I actually got 2 admits. It was on 2 different shifts, but I got the experience of getting a new admit patient. And the way you go about it, you know, of course, you follow all the required documentation in the chart, and then you get an RN to go behind you and validate that the findings that you did chart was true. So that was different. I don't know if anybody is an LPN watching this, or, you know, are able to do that at their particular hospital, or if you're a student, this is just some good information to know that, you know, you may work at a hospital where LPNs actually do the new admits. And y'all, I can keep going on and on about the experience. Just in these past 3 weeks, I have learned so much and just had so much opportunity to grow as a nurse and making me more confident in my skills. I mean, dude, I actually got to take out a vaginal packing. So you know how like you pull rope out of a magic hat, like you go to a magic show and they're like pulling rope or like a ribbon out of a hat? That's exactly how it looked, pulling the vaginal packing out of somebody's vagina. It was just like pulling until eventually it stopped. Sorry, y'all, thought I seen something crawling. I'm in the country, so I thought I saw something moving in my peripheral. So that was pretty neat. And y'all, I had got a patient the other night. She had bacterial enteritis, and that's like basically bacteria attacking the heart muscle. So she became septic. She was an IV drug user, so that's what actually caused her to get the bacterial enteritis. And she had kept saying she had vision changes. The previous shift nurse didn't, you know, think anything of it. So when I actually did my assessment, her eyes were like red, runny. Her pupils were gray and sluggish. And I asked her, I said, hey, how many fingers am I holding up? And she was like, I can't see anything. I was like, okay. So I used my pen light and her pupils pretty much stayed dilated. They didn't constrict or anything. So I went, let my preceptor know and my charge nurse know. So they actually contacted the nurse practitioner. So she ordered her some like antibiotic eye drops. So I gave that to her. It didn't really change much, but the nurse practitioner also had reached out to the eye doctor. So later that night, the ophthalmologist came, and he asked me about what was going on with her, and I was like, well, she just randomly had vision changes tonight. There were no reports of it in the morning, and you know, I'm a little worried because she can't see. She said everything just seems like a shadow. So he went check her out, and when he came back, he was like, she needs to get transferred like immediately. She has, I can't even pronounce the name of it, but basically the bacterial enteritis was so septic that it traveled to her eyes, so she was losing vision. And he said that she was going to have a procedure where they inject antibiotics into her eye and remove all the lubricant out of her eye in order to try to save them. But he said it was very rare, that he hadn't seen anything like that. It was like 1 in a million chance of something like that happening. So it was really important to try to save her eyes if they could. So that was pretty interesting. I mean, being a new nurse, and the fact that I was able to assess that and, you know, kind of change her life and get her the proper help she needed, that meant a lot to me, that I am actually being effective in what I'm doing currently at the hospital. Even though I kind of got nervous and was like, I don't think this career is for me. Like, should I go back to school? Why did I choose nursing? But I know why I chose it, because I want to make a difference in people's lives. I want to be there for them, for people who maybe can't reach out and speak on what type of help they need, or can actually describe what's going on, how they're feeling. So guys, I hope y'all enjoyed this video. It's getting late. I normally work nights, but I'm about to just relax and enjoy this time with my family, because I live an hour and a half away from here, so I came visit for the weekend. So if you like my video or have any more questions about what I do during the night, just let me know. Please like, comment, or subscribe. Hope to see y'all again. See y'all.